Well, hello, everybody. First of all, I have a very unique voice today. Laryngitis has been following me around. And here in Texas, it's still a little bit drunk and thinks it's the middle of summer. So we still have 95-degree days. So the allergens don't know what to do. So I apologize for that ahead of time. But I was really excited to be able to share the message that I have today to a broader audience. It's my understanding that everybody hanging out with us today is a practitioner or in academia or a social work student. And so I'm among family and friends, regardless what state we're in, and I love that. So before I dive right into my presentation, I just wanted to let you know a little of my motivation behind my research. I am a cisgender female, and I journeyed in hospice for many years. And it was in that journey that I really saw how things at the end of life can be very different for our LGBT population, and especially with our transgender population. So I didn't have much knowledge, but I certainly had interest and compassion in being an ally and understanding. I also had a great aunt by birth, great uncle by life, that was born in 1912, born as a female, identified as a male, and lived his life as a male. So if you can imagine, take a little time trip with me to 1912, you can imagine what his journey was like. I experienced his journey simply by being a great niece and had a lot of questions about parts of his life. And so in completing my research, it also helped me have an increased understanding of what his journey was. So I like to honor him whenever I give this presentation. So I'm going to go ahead. Well, actually, the other thing before I start the presentation, I want to stress that the topic of transgender elders is huge and much beyond the scope of our little time together today. So one of the handouts you will be getting is a handout that's a PDF that's from, excuse me, from the National Center for Transgender Equality, that really is kind of frequently asked questions about transgender people. And I think that it's vital for all of us to review and to understand. And it's beyond our full discussion today, so I like to provide that resource, okay? So now let's dive in. Let me get my presentation shared. Okay, here we go. So you already know a little bit about me. And so I want to kind of dive in. What we really want to look at today is specifically the experience of trans elders when accessing healthcare. And when I talk about healthcare, that could be the hospital, a clinic, mental health care, senior housing, assisted living, rehab, long-term care, all of those pieces. And so I'm imagining that many of you on this today work in all those different settings. So what I'm relying on you also is when we have questions or time for statements, I would love for reflection on this content also. The research that I completed was in Texas, so I want to highlight that, but the content is universal and across the board. So when we first start, I just want to make sure we're all on the same sheet of music when we're talking about what it means to be transgender. So I quoted some things from the National Center for Transgender Equality. So transgender people are people whose gender identity is different from the gender they were thought to be at birth. And that's a really broad statement, but that's the platform we're going to be working from today. Trans is an abbreviation, it's shorthand for transgender. So when I talk about trans elder, that's how that synonym or phrase comes to be. And I want to stress that the best way to understand what being transgender is like is to talk to transgender people, to listen to their stories, because every story is different and every journey is different. So what I share with you today is information that was shared from the journey of the trans elders I met with during my research and that I've met with during my practice. But this is by no means the full story of everyone who identifies as transgender. So because my voice is a little whippy, I'm going to let Josie and Poppy share a little message with us. And I think that this video can put us in the right headspace to understand that the scope of the transgender experience, my great uncle from 1912 to a young transgender female that's 13 years old, is a huge difference right now. There's similarities, but as practitioners and as social workers and future social workers, we need to broaden our mind to understand this. So I'm going to let Josie and Poppy talk to us a little bit.
How did things go when you were my age, Josie?
Well, it was a very different time, Poppy. I can only say I was born in rural Northumberland and I met so very few people. I didn't meet a girl until I was 5. And I knew as soon as I met her, I thought, oh, that's me. It wasn't like I could consider transitioning or thinking I was a girl. This just wasn't on the agenda. We had no internet, we had no television, we had no radio. So I was left in a village full of coal miners, quarry workers. It just steadily got worse inside of me, and by the time I was 9, I knew that this body was wrong. There wasn't any words that you could use to tell people. So I didn't have any options, but by the age of 12 I was left just disappointed that I wasn't entering any sort of puberty. It was obvious I was never going to be a girl.
It's hard and complicated.
It was hard. I went on to get a good academic career, but ultimately the strain was there all the time. But that's totally different to your experience, isn't it?
I was able to talk to my parents and my friends and my family about it and be open about it.
Yeah, that's wonderful.
But I guess when you were younger, you didn't have the opportunity to be open about it like I was.
But the funny thing is, I think my mother knew. There was always a special way she treated me. And then at the age of 60, I woke up. The path I took for surgery was a disaster. And that sort of floored me for a bit. And it's sad when I think back on it. There's no need for him to be as offhand as he was. I had it corrected, and I went to California, and I saw there a wonderful lady called Marcy Bowers, and she is one of the top 3 gender surgeons in the world.
I perform about 150 per year. I was the first person with a transgender history to actually perform the surgery.
And she was horrified when she looked at me. She really was. And I said, "Can you put it right?" She says, "Yes, Josie, you've come to the right place. What are you doing Friday?" Brilliant. So you see me now, but this is the end of my journey, Poppy. It's more to do now with not who I am, but what I do. I know that you're going to have a much fuller and complete life. And who knows what miracles technology can bring. All right, maybe one day it may be possible for you to have your own baby. I always think that that's a possibility. That's what I dream for, that we can become what some awful people in this life call real women. Do you know what I mean? We are real women, we are real girls. Right? But for some reason, some people think we're not. And can't ever be real women. You know what a real woman is? Am I a real woman?
Yes.
Yes, of course I am. You're a real girl.
It breaks my heart, it really does, because I always wish everybody else could have the opportunity that I have, and I feel so terrible. And if there was any way I could go back in time and make things right, I would.
Me too.
I would give anything for that.
Me too. But the thing is, things have developed and you have grown.
If I hadn't transitioned, I wouldn't be happy in my own body, and I wouldn't be confident, and I'd just be depressed, and I wouldn't really want to be around anyone or anything. I didn't know who I was before, but now I know who I am, and I'm Poppy.
You have come out of it, and I just wish you well in the rest of your life.
Thank you so much, Chelsea.
You're so beautiful.
Not as beautiful as you.
Poppy.
And so a few things that I wanted to just highlight from that video is just showing that everyone's experience is different. But because society and the historical trauma that our trans elder individuals dealt with, there's some additional things we need to be aware of as clinicians. And that in no way states that right now, today, the transgender battle and rights is not strong, but it's very different than it was for those who are now in their 70s, 80s, and 90s, and even 60s. So in looking at current literature, it really indicates that our trans elders continue to face barriers. And those barriers come from deficits in healthcare providers' culture and clinical knowledge of transgender healthcare needs. And I think Josie's experience with having a really botched, non-dignified surgery is just one example of, without cultural and clinical knowledge, what can happen and has happened. So if we're looking specifically at our trans elder clients, there were a lot of things that they had to do either out of country or, under the radar. And so that trauma follows them. There's still refusal of care, verbal harassment, and even physical abuse. One of my private clients is a transgender male who's in his early 60s. And we've had a crazy journey trying to find senior assisted living housing for him. We're going to talk more about that, but we see it in the literature, but I share that I see it every day, and I'm sure you all do too. Ambulances that have refused to transport him to the hospital. Home health nurses that have refused to provide treatment or recognize his correct pronouns, that sort of thing. And those are just minute, but it's important to be aware of. Then other studies show us that 70% of transgender individuals as a whole report having experienced discrimination by healthcare providers. And this isn't talking about in the 1950s or the 1960s. This is literature from 2016 17, 18, 19, 20 from the last 5 years and to current. And so despite growing research efforts that are focused on LGBT aging, what you will notice is a lot of times it encompasses the LGB side, but the transgender side, which has a whole different, has different medical treatment elements to it, a lot of times may or may not be included in that actual research. And so I am but a small drop in the bucket of providing a message to some amazing researchers who are really trying to expand this body of knowledge. And so when I began to look at how could I get a picture for myself, kind of looking at the statement of the problem was the barriers we discussed and the disparity that were coming out in the literature. I'm going to go into more detail of those as we go along. The study that I did, I actually did what's called phenomenological interviews, which it took me forever to pronounce that word, but basically it's interviewing people who are experiencing the item or the problem or the journey that's being looked at. So I was blessed to have a number of trans elders who were willing to speak with me and help educate myself so that I could share this information. So when we look at the stigma, there's historical prejudices, which we can go back in time to, I remember even my great uncle that I spoke of, one of my earliest memories is that he would always send beautiful like crafts, arts and crafts through the mail, macrame, placemats, paintings. And I just thought he was incredibly crafty. What I found out later on through my mother, as she was aging, was that she was actually, my uncle, he was actually hospitalized for ECT treatments, electric shock treatments during those times. And that was a part of his therapy, of them trying to transition him and make him live in the biological body versus what he identified as. And that was a unique experience that was very common. Talked about the gap in research, looking at the trans elder community. And their voice is a little hard to be heard. And part of that is because historically, and this kind of starting in the 70s, that's a whole nother presentation, but there began to be some research on individuals who identified as transgender, but what ended up happening is the research publications were twisted to really make it look like they were an oddity and that it was more for entertainment value, or that they were misfits in society that needed to be cured. And so that experience really limits, especially elder transgender individuals, from wanting to share or be open outside their safe, comfortable circle. And so why Texas? Now, well, not only because that's where I'm located and have practiced as a clinician, but Texas is the second largest adult LGBT population. And as of 2022, there was at least close to 12,000 trans elders, 65 and older. Now, I want to footnote that these numbers are based off best case gatherings, because in census and in surveys, number one, the questions aren't asked. I mean, just look at the majority of healthcare forms you fill out, right? And then also the fear of, now if I do identify that I'm transgender, I have had so many historical traumas, I don't know that I want to make that known. So I want to footnote that. But Texas ranks 39th in public support for LGBT rights. So second largest adult population, 39th in supporting rights. We have a lot of work to do. And so we know that current research tells us the geriatric population by 2030, which is coming up on us, these geriatric populations are doubling. And those of you that already work in geriatric or healthcare populations, home health, you're seeing this mass growth. And so if we're looking at in just 7 years, we could be looking at close to 25,000 individuals, trans elders in the state of Texas needing support. Now, I want to footnote that I'm not bashing the state that I live in. I'm just stating our facts. And then I also encourage you in the resource guide, there's, in the references, there's links to all of these references, and some of them you can search down to your area, to your county, to your state, and find out what story your state tells. And so before I move on, let me come back to here. I want to just take a pause and ask, and I don't have view of the chat, so I'm going to let my handlers let me know if there's any questions or thoughts before I move on.
Okay, so if you have a question or a comment you want to put in the chat, there are actually a couple here. So somebody posted a link to the Poppy and Josie video. Somebody also noted that they met the surgeon in California and she's wonderful and down to earth. Anyone who needs services can please contact her.
That is awesome. Thank you for sharing that. And yes, thanks for sharing the link in the references of the PowerPoint. That link is also there just in case you don't get it copied out of the chat. Well, wonderful. Thank you. So I'm going to forge ahead. Does that sound good? All right. So in looking at the problem and in research, it's important for us to have a theoretical model that we're making assumptions off of, that we're making hypotheses off of. And so I really looked at the social ecological model of stigma. And I want to break it down so that this model looks at 3 different levels of stigma. So when you're analyzing it, you can look at all scopes of how stigma may be impacting the population you're looking at. So when we apply this to transgender individuals, structural is the first piece that it looks at. So when we talk about structural, we're talking about policies, guidelines, insurance, facilities, hospitals. And so a lot of the structural barriers that are stigmatizing our policies and practices. One very simple one, and I'm getting ready to have some medical care done. And I was kind of excited to see that in some of the forms I was filling out, and my care is going to be in Texas, there was not just a binary selection of gender. It wasn't necessarily as welcoming as I'm imagining might be important for some of our trans elders, but that was interesting. And another big piece of lack of healthcare provider training regarding transgender needs. So I'm imagining that many of you or some of you on this call, like myself, prior to my work and continues, is I don't know what I don't know. I've lived in this cisgender shell all my life. And so I have to really make effort to reach out and understand. And so I was able to find that there are very few actual curriculum for healthcare providers that specifically, that number one, that talk about caring for LGBT as a whole, but especially for transgender needs. So some of the things that are going to come out as I go on are guidance that I got from the individuals that I had the privilege of interviewing. And then also barriers to healthcare access, or obviously all of the barriers we know across the board, economic, ethnic, gender inequality, that sort of thing. Then let's look at the interpersonal impact of stigma. So I'm an individual and I go to get care, and being refused care brings it more interpersonal. It's no longer policy, it's now I'm receiving inappropriate care. I know that one person I spoke with shared that they were in the hospital and they refused to call them. I mean, he'd lived as a male for 40 years. He had come out probably when he was about 60, but he always felt it. And they refused to call him by his pronouns, got a psych consult and said until he was willing to be honest about the fact that he was female, that they were going to give him a psychiatric referral. And you think this happened in 1950? No, this happened 3 years ago. 3 years ago. Workplace discrimination. So we heard a little bit from Poppy that he had an academic career, that she had an academic career prior to coming out. So as a male. But that fear of, if I come out, what will happen? One of the individuals that not only did I interview, but was a partner in my research, she also had a very lucrative career as a male, was married and had 3 children, and then came out at about 55. And the workplace said, we're going to accept you back, all of that. But all of a sudden, all the big clients that he'd had for years started being taken away from him. So as she transitioned to her true self, no knowledge disappeared, no ability disappeared, but the way the workplace, the way the clients discriminated against her had drastic impact on her career. Also, physical and sexual assault by staff, faculty, patients, and residents. A few of those examples might even be that, and these are quotes from some of the folks I worked with, they'd hear jokes in the hall about who had to go see the she-he, and if they were going to get a glimpse to see which parts they had. All of those types of that are definitely sexual assault, verbally, but also very inappropriate when providing hands-on care, bathing care, and then also a lot of religious entities of your abomination to God. If you would just accept Christ as your Lord and Savior and live as God made you, just constant. And this is ongoing. This isn't in the past. These are things that are continuing to happen. Another example I'll give on that is the client I mentioned who we're trying to find an assisted living for. We will meet with the staff and they will indicate, or the administration, I should say, yes, we absolutely are very open. Gender identity is very important. We're an open facility. But then what happens is the actual residents living in the facility who are in their 70s and 80s and 90s and have been raised with stigma and raised as cisgender and raised with myths are very insulting and disrespectful, and the staff don't step in. So that's kind of a hollow promise. Not that the other residents, it's very difficult to help provide education, but it is vital to provide safety and security. And then lastly on that model is looking at the individual stigma, how they look at themselves. So because they had past negative experiences, they just think they don't deserve the same access to care as heterosexuals. And many and this applies across the board, but we're looking at elders, have just not gotten health care, not managed diabetes, blood pressure, cardiac issues, chronic kidney issues that come from having to hold urine because there's no restrooms they're allowed in. All of those, I'm not going to say routine healthcare needs, but things that people go to the doctor for all the time, they resist going because they know how they're going to be made to feel. So they begin to think, I just don't deserve care. And then obviously a lot of fear of disclosing the needed information that they have to about their transgender status. So they just avoid seeking treatment altogether. So within my interviews, I broke it down into themes and just pulled out some highlights. So these were interviews with trans elders. The youngest was about 75, the oldest was about 83. I will state that all of them are very open about their transgender status, and were willing to be interviewed. I think it goes without saying that it's very difficult to find individuals that are willing to lay bare such intimate conversation and detail given past experience. But so one of the biggest things is insurance coverage. So up in a few years prior to 2017, I don't remember the exact year, there was wellness coverage was added to a number of insurances that meant that it would cover transgender wellness coverage. So maybe an individual who was a trans female, their coverage for their hormone treatment, maybe they'd had top surgery and they needed mammograms and monitoring there, but maybe due to choice or to medical barriers, they weren't able to have full transition surgery. And so they still needed like a prostate exam. The trans wellness coverage would allow coverage for all of those items. But in 2017, that was taken away. So a couple of the individuals I spoke with had transgender wellness coverage under their spouse's insurance. And when that was taken away, they no longer had insurance coverage for hormone replacement therapy and for a lot of the other medical services that they needed. And so either they went without or they had to pay out of pocket. And so, like, as I mentioned, a number of them have indicated, of the people I interviewed, that they really just don't go to the doctor anymore unless it's a dire emergency. One individual I interviewed was a veteran, had VA and Medicare, and they had full coverage for all of their services. So when I present this, there are a lot of barriers, but there are also pockets of individuals who may have found some solution. So I want to share that in regards to coverage. But I heard very commonly that a lot of people, especially starting like in the 70s, when hormone replacement therapy began to be a little bit more, have more knowledge of it, they would go to Mexico to get those. And some have just stayed getting that. The problem that happens is there isn't necessarily a quality control of them. So there are many individuals who have had medical and fatal reactions to having to go out of country and take health care that is non-regulated. We've talked some about professional attitude. And one of the things they stressed is that the person that supports the doctor is just as important as the doctor. They stated a nurse with an attitude when they come in could ruin the whole experience. So support staff, from the receptionist to the person taking, the medical assistant taking vital signs. There needs to be a cultural shift of understanding and an ability to provide dignity and respect to all. So I'm sorry, go ahead. Was there a question?
I don't
Okay.
think so.
Okay. So there's still a lot of institutional prejudice that is against anyone that's not binary. And I guess I'm using some terms I'm assuming individuals may or may not know, but when I state cisgender, it means I identify as the gender I was born as. And when I say binary, it means only a choice of male and female. So just wanted to clarify that. And so a lot of microaggressions. I heard the term death by 1,000 paper cuts describing those microaggressions, that they said, if I told you just one or two, you'd think that's not a big deal. But they said, if you understood how many years and how often it happened, you'd understand our avoidance. So then the overall experience that it's not personally or emotionally something that they feel comfortable doing. It was very common for me to hear, if I don't go to the doctor, and if I end up having a stroke or I'm incapacitated and need nursing home care, it's just easier to die. That was a common thread. So much so that a number of individuals said they already had a plan in place. In the state of Texas, physician-assisted suicide is not legal, but there are states where it is, and they already had plans and connections in states where that would be. So the fact that they would rather die than to have to be placed into a rehab facility just is awakening to me, and realizing how much we have to do better in our care. When we're looking at future care needs, again, comments about not wanting elder care. Some have been able to maintain family ties with their children or their family members, and they know they have family members to take care of them. But many trans elders were very much disowned and separated from family. They may have never had children, or if they did, those children have disowned them. So having a familial circle to draw off of is rare. The other piece is that a lot of trans elders have created their family of choice, but that includes many people who are elderly themselves. And so being able to care for each other is becoming more difficult when that's what they used to rely on when they were younger and more able-bodied. And so when I asked them, what's important for me to pass on? What do you want me to pass on from your voice? The three main things was, we need to be treated with dignity, regardless of how our bodies look. And I think that we heard, like from Poppy, sometimes because of maltreatment of a million different things, their physical body may be shocking, and it's vital to be treated with dignity. Intentionality is important as the words that come out. So just laying words to it, calling somebody by their preferred pronoun is really hollow if the intentionality and the respect doesn't back it up. And then the last statement was, when you're older and trans, people no longer really listen. So we really need young, strong, loud people in the movement. And that call is for not only younger transgender, younger people that are in the LGBT community, but younger allies. And all of us on this call are younger. We're considered younger. We're the voices right now in our profession. And so we need to continue to be a voice. So then I also had a focus group, and I had representation from the spiritual community, administrative, military, medical, and mental health. All of the people that were a part of the focus group are individuals that actually work in an environment that currently come across the need to care for trans elders. And what was very eye-opening in this focus group is, as with myself, the desire to know what I don't know was there, and revealing how many things we didn't know was kind of, I don't want to say earth-shattering, but it was humbling. So when we looked in the spiritual realm, the spiritual responses weren't necessarily just from clergy, but from people who, you know, like myself, working in hospice. There's definitely spirituality portion to that. But so just looking at how do we do better in creating a culture of generosity and compassion that goes beyond just looking at individuals who are different than us. The reality that theology, the majority of theology is really not equipped to meet the challenges that people face in their lives, specifically in the LGBT population. There are faiths, and I'm going to say specific, maybe churches that are doing better at this. And we have a number here in San Antonio that are really trying to decrease a lot of this stigma. And I'm sure in your corners of the world too. But, you know, elders often seek healthcare guidance from their spiritual leaders. That's just who they go to. And if you're a trans elder and you're wanting to seek guidance, which spiritual leader can you go to? May be very slim. Then also looking at policy, they were challenged to look at their own policies within their organizations. And these statements came from administrators like that were at the, you know, COO levels, chief operating officer levels. And they said, as far as the operation manual, there's not really a policy for LGBT and specifically not transgender in place. There's cultural sensitivity, but there wasn't specifically in the operational policy. So they said, but before I leave that organization, I guarantee there will be. Another organization said, we call them guiding principles and values. It applies to anybody that comes through our door. But the conversation went on to say that even like with diversity training, we can't say we treat everyone the same because everyone is different. So there needs to be more energy put into the diversity and diversifying training. And then in the military portion, one of the individuals had identified with the LGBT population portion of it, and said, you know, when I was in the military, I would have never let people know I was out because we were threatened to be put in state hospitals. We'd get kicked out with dishonorable discharges. And now they're expecting us to open up and have the conversation, and it's really scary. There are some of our trans elders who did get dishonorable discharges, do not want to fight it, or afraid to fight it, do not have the benefits they deserve. Issues with the DD-214, which what that is your golden ticket in the military. That's like your discharge pass. So when you get out of the military, whether it be after serving a certain number of years or retiring, your DD-214 is your proof that you served, where you were at. It's how you get benefits. It's how you qualify for military barriers, etc. And if your discharge DD-214 puts you at your biological gender marker, and you've lived your life as a different gender, it can be pretty devastating to have to go through and have them, you know, like looking at on your marker, the name can't be your chosen name. And so there's some efforts that were being made in that. I don't have an update on that, but that's important to look at. And then all of a sudden, disability benefits, if they were issued in one gender, and then they transition, there's still some questions up in the air. And I think there's been movement made on this, but I don't know the details. In medical, we've gone over a lot of that already. There's a lot of physicians that say, I want to do better, but I don't know how. And we can't just sit around and expect trans elders to teach us, right? Like with any diversity, it's our responsibility to reach out. And so there are curriculum that's being written, a lot of universities that are doing some phenomenal work on that. And so if you're a part of an organization, I'm not asking you to go in and be like, we're changing the whole world here, but you can be a voice to prompt question and to begin to have, begin a discussion, okay? Another issue, like in the state of Texas, I'm sure this is probably the same with most Medicaid guidelines. It states that, like if you're in a nursing home, you don't get a private room, has to be semi-private. And in the nursing homes, you have to have the same sex in each room unless you're married. So that's also been a real barrier for trans elders needing to be placed in nursing homes that are on Medicaid, because a lot of facilities, excuse me, are not wanting to accept them because they'd have to put them in a private room. And it can be very convoluted. And then misgendering on death certificates, which can impact insurance policies. So if they were living under a different name and gender, but the death certificate is written in their biological gender, it can really impact payout of insurance policies and that sort of thing. And then under mental health, just as a social worker, you know, we may not know the answers, but we need to ask the questions. And so that's a little bit about what we're doing here today. And so just kind of in wrapping up, you know, what can we do? So I talked a little bit about organizational change, looking at incorporating, you know, LGBTQ into the cultural competency training. If you are someone on this call that has the power to do that, start a conversation. If you're not, speak to an, you know, you can still start a conversation, right? But definitely be aware of it in your own one-on-one scenario. And then also, when you're adapting your service delivery, you know, specifically sensitizing to historical trauma. So if I've been to a lot of trainings about trans youth, my view of what a trans elder needs is not going to be the same, because their journey has been much different and what they need is much different. At a university level, this is a part of what I'm trying to do, is to share the message. At my university, I'm the content expert for our elders courses, and have totally rewritten them to just incorporate the LGBTQ umbrella throughout all. It's not just like a chapter. It's infused within all content. And then on policy advocacy, be aware of what's happening around you, what's happening in your city, state, and national government. Be collaborative, be a part of NASW or whatever policy entities you feel comfortable with. And be aware that at a national level, June 15th, there was an executive order. You all may be aware of this or may not, that our current administration has put out on advancing equality for the LGBTQ plus population. There are specific sections of this that talk about looking at addressing discrimination, social isolation, and health disparities faced by LGBTQI plus older adults. And then there's kind of a guideline. Again, you can read this and find a link to it in the reference section that you'll be getting. So on that note, I will stop sharing and come back to you all. and see if, as we wrap up in our last few minutes, there's any questions or comments that any of you have.
While folks are thinking about that, there's just a few comments in the chat, Kathy. So so there was one individual who wanted to offer their contact information as sort of a help for this for trans-related issues. And then some comments about someone wrote lifelong discrimination, and then to arrive at older adulthood and have these continued experiences, it's no wonder that they do not want to seek healthcare and social services. And then there was another comment. It is so important for both allies and people in the LGBTQ+ community to speak up for older transgender individuals. As a lesbian woman, I see people within our own community discriminating against transgender people. It breaks my heart. There's enough hate coming from the outside. Transgender people encounter more discrimination, especially those who are older. This needs to be talked about more. And thank you for speaking up about this.
Thank you for that.
There's some thank yous and notes that you have a good presentation. Does anybody have a question or anything they'd love Kathy to talk more about?
Hi, I'm Nicholas Treach. I'm out of the Eastern Panhandle. I wanted to let people know of some resources that are available. There is a conference coming up, I believe October 6th and 7th. I'll put the link in the chat. It's called the Trans Pride Pittsburgh Health and Wellness Conference. It's going to have a ton of speakers. It's going to be focused on transgender, binary, non-binary experiences, educations. And what's really cool about this is if you are a part of the community, identifies transgender, non-binary, or gender diverse, that there is a free community caregiver ticket available. So if you are a part of the community or any clients are a part of the community, they could be able to become educated, participate in this conference for free. If you're in the Eastern Panhandle area of West Virginia, there is an organization called the Frederick Center, and they actually do a number of youth groups, adult community groups, and they've just started doing some elder groups for folks who are part of the community to connect with others, share their stories, and kind of build connection. And the last thing I have, I don't think I'm ready for that information, but I will stall as long as I can to look it up. There is a group called the Tri-State Gender Collaborative, who has been meeting to work on building resources in Pennsylvania, Ohio, and West Virginia, and to help collaborate with one another to address some of the things that we are discussing here in this meeting. And so a great way to get in contact will be through the Facebook page. And it has a lot of great resources. There's even an email listserv if people are looking for resources for elders or youth in the area.
Thank you, Nicholas. Does anybody else have questions or comments? While people are thinking, I just want to remind folks that I put in the chat a link to a brief evaluation survey. So if folks have a minute to do that, I'm going to repost it again now so that it's fresh in your feed.
I was just scrolling through the comments, and I think it's Spence. It said Two-Spirit, Native All Genders, 48 West Virginia LCSW here. I'm assuming that's what you identify with. And I thank you for pointing that out and being there. I think that there's such a breadth in another presentation that I have. It's been so wonderful to have some focus on the Two-Spirit portion. So thank you for just self-identifying there if that's what you were doing. I think I read it right.
Yes, you did.
Thank you very much. Okay, well, I am excited that you all have shared some great resources for your area. And And I'm glad that we could chit chat today and just prompt thought. And so I don't have anything else if you all don't, and I can let you get back to your day.
Yeah, thank you, Kathy, so much for this presentation. It was really great, and your research is really important, and excited that you're doing it and sharing it with us. So thank you for taking the time. For those of the rest of you, thank you for logging on for our seminar today, and we will be sending announcements about next week's seminar shortly, and I hope to see you all there. So thank you. Thank you again, Kathy, and thank you everybody who joined us today.
You're welcome. Bye-bye.